Good afternoon, everyone. Thank you for coming to the Iridex Speakers Forum. I'm Joan Stauffer, and I manage our clinical education programs. And it's my pleasure to introduce Dr. Martin Mainster, who will talk about continuous wave and micropulse 577. Thank you, Dr. Mainster.
Thanks a lot. This afternoon I'd like to speak with you about CW and micropulse 577 yellow laser photocoagulation. I'm a consultant for AMO, Iridex, and Ocular Instruments, and I don't have an interest in any product manufacturer or patent. Retinal photocoagulation is effective, but it's also destructive. And in the past, the prevailing view has been that laser therapy had to destroy rods and cones that consume oxygen, or RPE cells that produce angiogenic mediators, in order to be effective. That perspective has been disproven now by numerous clinical trials and better understanding of the cellular and molecular changes that are induced by laser exposures. Photocoagulation upregulates inhibitors and downregulates inducers of VEGF-related angiogenesis, as shown by microarray and quantitative PCR techniques. Photocoagulation induces migration of bone marrow-derived stem cells to exposure sites, where they can differentiate into and replace dysfunctional or injured cells. Photocoagulation downregulates matrix metalloproteinases, which degrade extracellular matrix, and it upregulates their tissue inhibitors, thereby inhibiting initiation and maintenance of angiogenesis. Additionally, under certain circumstances, laser-induced RPE proliferation may upregulate MMP production, rejuvenating Bruch's membrane. Photocoagulation decreases RPE angiogenic transcription factors, including VEGF, to levels lower than those before laser exposure. And finally, photocoagulation upregulates pigment epithelial-derived factor, PEDF, which is a powerful inhibitor of angiogenesis. Prospective randomized controlled clinical trials now prove that subthreshold micropulse photocoagulation is an effective method for treating diabetic macular edema and is as effective as conventional, more damaging photocoagulation. More significantly, these controlled trials now prove that subthreshold micropulse photocoagulation for diabetic macular edema improves macular visual sensitivity, whereas conventional damaging suprathreshold ETDRS protocol photocoagulation decreases it. The bottom line is that subthreshold micropulse photocoagulation can be constructive without being destructive, whereas conventional suprathreshold photocoagulation causes permanent damage to rod, cone, and retinal ganglion photoreceptors, corresponding loss of rod-mediated scotopic and mesopic vision, as well as circadian photoreception, visual field loss, and post-operative scar expansion. So to borrow a term from our friends in cataract surgery, the fact of the matter is that subthreshold micropulse photocoagulation can be considered as a new premium photocoagulation, and although it requires additional clinical time, it reduces retinal damage and provides superior post-operative visual sensitivity. Micropulse photocoagulation reduces damage by using subvisible or barely visible treatment endpoints. Photocoagulation occurs when laser radiation is absorbed primarily by melanin in the RPE and choroid. Light absorption in pigmented tissues converts laser energy into heat, increasing the temperature of the pigmented tissue targets. Heat conduction spreads this temperature rise from pigmented tissue to overlying neural or collateral retina. Overlying retina damaged by heat conduction loses its transparency and scatters white, slit lamp light back at the observer. Retinal whitening is the optical signature of a retinal burn. More damage means less transparency and a whiter lesion. But there are many types of thresholds other than visible lesions, and these include hemorrhage, which occurs typically at exposures 3 times those required to produce ophthalmoscopically apparent lesions, and at a half to a quarter the exposures required to produce ophthalmoscopically apparent lesions, You can get angiographically apparent lesions that you can detect with fluorescein angiography, but that are not apparent ophthalmoscopically. At 1/10 the exposures required to produce biological effects, you have maximum permissible exposure levels, which are documented and detailed in international safety standards. In clinical terms, subthreshold means invisible. Smaller retinal irradiances produce therapeutic effects with lower retinal temperature rises that cause less or even no retinal damage. Additionally, micropulse photocoagulation reduces damage by localizing laser effects with very short pulses or micropulses. This is the temperature rise in the center of a 200 micron diameter laser spot. For very short exposure time, temperature is increased only in the retinal pigment epithelium and the choroid where light is directly absorbed. For lengthier exposure time, heat conduction spreads temperature rise into the adjacent neural retina so that by the time you get to 1/10 of a second exposure, temperature rise in the neural retina adjacent to the retinal pigment epithelium is almost as high as it is in the retinal pigment epithelium and choroid. Neuroretinal damage is caused primarily by heat conduction, and shortening a laser pulse can localize its chorioretinal effects. If you want to localize those effects to the retinal pigment epithelium, the retinal pigment epithelium is about 10 microns in height, so you need to basically limit your laser exposure to about 7/10 of a millisecond in duration. But if you deliver all that laser energy in a single pulse, 7/10 of a millisecond in duration, you'll wind up frequently with hemorrhage and post-operative choroidal neovascularization, so that's a real bad strategy. But you can work around that strategy with micropulse photocoagulation, which provides power in a burst or envelope of micropulses rather than in a single continuous wave pulse. Micropulse photocoagulation produces these individual small pulses, and there's insufficient time with each pulse for heat conduction to spread temperature rise to adjacent sites. Each micropulse denatures only a small fraction of target tissue molecules, and repetitive micropulses combine to produce therapeutic effects. A third way of localizing damage with micropulse photocoagulation is optimizing laser wavelength. Numerous laser wavelengths have been used for retinal photocoagulation and laser trabeculoplasty. Macular pigment in the inner and outer plexiform layers isn't a clinically significant absorber for any of the wavelengths used in contemporary ophthalmic practice. But melanin is the most effective chorioretinal absorber, and its absorption decreases with increasing wavelength, as does that of deoxyhemoglobin and also oxyhemoglobin, which has an absorption peak at 577 nanometers in the yellow part of the visible spectrum. Now, red and infrared laser light cause deeper, less visible, and often more painful lesions. Conversely, deeper lesions may reduce damage to retinal ganglion photoreceptors. A common misperception is that red light is useful for treatment when there's hazy media or vitreous hemorrhage. The fact of the matter is that the retina is visualized with white slit lamp light, not with red laser light. Treatment in hazy media is limited by visualizing retinal targets with white slit lamp light, not by difficulty in getting a laser beam to a visible target. No controlled trial has ever proven the clinical advantage of one laser wavelength over another in standard grossly suprathreshold retinal photocoagulation, but dye lasers exploited the 577 nanometer yellow peak of oxyhemoglobin in order to improve the comfort and convenience of standard retinal photocoagulation. These 577 nanometer yellow laser treatments had excellent lesion visibility, low interocular light scattering and patient pain, negligible xanthophyll absorption, and high choriocapillaris absorption for more uniform effects in patients with light or irregular fundus pigmentation. In fact, there's about a 15% reduction in the variability in laser light absorption with 577 nanometers as yellow light as compared to 532 nanometer green light. Dye laser photocoagulators gave surgeons the opportunity to select yellow, orange, or red treatment wavelengths. But two things happened when dye lasers were available. First, dye lasers became extremely popular with retina surgeons. And second, most clinicians set the laser at 577 nanometer yellow and left it there. And then the dye died. It turned out the problem was that dye lasers were costly, complex, difficult to maintain, and they didn't have enough power for laser trabeculoplasty, so you needed a different laser to do that. So despite the clinical effectiveness and convenience of 577 nanometer yellow photocoagulations, dye lasers were just economically unfeasible. And ophthalmologists returned to less optimal and less convenient, but available and reliable green or infrared photocoagulators. Well, it's taken 2 decades for laser technology to catch up with clinical demands. But new semiconductor laser devices finally provide cost-effective, reliable, solid-state 577 nanometer yellow laser light for clinical use, exploiting the same 577 nanometer yellow peak in the absorption spectrum of oxyhemoglobin that dye laser users found to be so effective. This new solid-state laser technology offers, in essence, a laser for all reasons. You have optimized wavelength, standard retinal photocoagulation, micropulse premium retinal photocoagulation, standard laser trabeculoplasty, and micropulse premium laser trabeculoplasty. The IQ577 photocoagulator provides 2 watts of dependable solid-state 577 nanometer yellow laser light for both posterior and anterior segment photocoagulation, and premium less destructive micropulse photocoagulation at a visible wavelength optimized for conventional photocoagulation. In summary, despite pharmacological advantages, laser photocoagulation remains a critical part of modern retina and glaucoma practice. Methods are available for minimizing collateral damage and increasing post-operative visual sensitivity, and solid-state laser technology now provides premium photocoagulation at a wavelength optimized for conventional photocoagulation. Thank you very much.